Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this ASPN podcast. Let's get started. I'm Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, you posted a LinkedIn post last week that got a lot of people talking and really I thought was well received by our colleagues. And you titled it as The Do Nothings. And it was based on a quote by Nick Saban saying, mediocre people don't like high achievers and high achievers don't like mediocre people. Can you kind of talk about that and where that kind of originated from?
Yeah, Patrick, first of all, good to see you. I hope things are good there in California. I think that sometimes you have a thought. And so, I see myself and my colleagues do hard work, do studies, do lecturing. I see other colleagues that really just do a great job in their local practice and things of that nature. And on one of my posts, which the one you mentioned, we had about 40,000 views of that post. And, I think some people know what I'm talking about. If you're mediocre, you need to raise your game. And I think that's important for all of us. Every day we need to try to get better. And if you're already a high achiever, you got to stay there. You got to work hard, whether that be in sport or whether that be in medicine or that be in research or be in your local practice. And then every now and then you'll have just somebody who's negative on every post. And then, I went to PubMed and looked at two of those people who were negative on a different post, and neither one had ever published anything in PubMed. And, it made me think, well, when you're critical of other people's studies and things, you should have at least a scientific reason behind it. And so I think that's why we created ASPN. It's not to tear each other down, but to bring each other back. So, if you want to be critiquing someone in a positive way where you make suggestions about better ways we can do things, that's one thing. But, I think it's time for all of us to raise our bar, Patrick. And that was what I was trying to say. And, I think the journey is to make each other better, make yourself better, and really try to elevate those around you. And if you're not going to do anything, get out of the way, because all you're doing is hindering our field. So that was my point. I didn't think 40,000 people would see that post, but they did. That's one of my top 5, I think, of all time. But I think that message is clear. And I quoted Nick Saban, who, I'm a West Virginian. I'm not an Alabama fan, but Nick's from West Virginia. But I think that led to a lot of victories for him and some losses. We're going to have our losses along the way. So that was kind of the story behind that post. Thanks for asking.
No, thanks, Tim. I think that hit home with me too. And kind of every time we've talked about on this podcast, raising everyone out, elevating our game and really doing it for the best for our patients, first of all, and for each other too. So I thought that was great. And thanks for talking about that. Want to announce our second sponsor for season 2, Saluda Medical. Their smart lip therapy has really been a game changer in my practice, Tim. I'm sure yours too as well. They have that 3-year double-blinded crossover RCT, and their team from Jim Sherman all the way down has been outstanding. Tim, can you just give a couple of your thoughts on Saluda Medical?
No, I think it's really great, Patrick, to see a new entry into the field. We need to have all the companies in the field do well and continue to be successful and productive. And Saluda, with this new technology, I think has really changed the way we think about dosing of the neurological system. So to have them sponsor the podcast, I think is wonderful. And, from Nagy McHale, who was first author on that 3-year paper, who's a dear friend, all the way, the clinical team who designed the research, and now the sales team, who are out there talking with doctors. I think it's been a great example of taking a startup company and getting to the point where they're going to be impactful in a lot of patients' lives. And there'll be some doctors who choose that is their primary implant. So I think it's wonderful to have their sponsorship. We greatly appreciate it. And as always, Patrick, our goal is to elevate the lives of our patients. And that's another option in our tool bag.
Absolutely. We also like to thank Mainstay Medical for sponsoring this season. I think that kind of great segue into introducing our guest today, who's going to share a little bit about his experience with the reactive therapy as well. So I'd like to introduce and welcome neurosurgeon, Vice President of ASPN, Dr. Stephen Falowski. How are you doing, Stephen?
I'm good, Patrick. How are you doing?
Awesome. Thanks for joining us again. Why don't you go ahead and start off talking about just a little bit of your background and training and why you decided to be a part of ASPN?
Yeah, sure. Absolutely. So by training, I'm actually dual trained in complex spine and functional neurosurgery. So I have a very unique perspective when I look at patients and spine patients because I came out into practice thinking I was going to be doing a lot of fusions and maybe a little bit of stimulators. And it turns out that the majority of my practice now revolves around neuromodulation, since I realize, the patients do so well, and we have to be more considerate of the patients we choose for fusions. But one of the things I love about being part of Aspen and help build it with Tim and others was that it's a very collaborative approach in Aspen. They embrace new therapies. We want to educate the space, and it was something I definitely wanted to be a part of.
That's great, Stephen. As Tim alluded to, we have, so many tools in our toolbox for a lot of these therapies, especially for axial low back pain. Can you kind of just talk about briefly your algorithm for treating low back pain?
Yeah, absolutely. Like I said, I have a unique perspective on patients, being a surgeon who also likes to embrace minimally invasive technology, embrace neuromodulation. But essentially, I think everyone starts with conservative measures, whether it's, NSAIDs, physical therapy. We'll start with things like injections. But once you're getting past the point of epidural steroid injections, if you're not responding to these therapies, is when we start looking at other even minimally invasive methods or conservative methods. And, as a surgeon, I'll evaluate their spine I'll look for spinal stability, and I'll look for nerve compromise. Those are the two reasons I think as a surgeon we would start thinking about open surgery. However, I evaluate patients right away for what is the mechanism, why are they having this axial low back pain? And then I try to look at all the procedures that we have, whether it's interspinous fusion, whether it could be the SI joint that's actually causing the pain. But then we look at other therapies like spinal cord stimulation. Is that more appropriate to do than, say, an open decompression or an open decompression infusion? And now with the advent of Mainstay, it's added to the criteria of things I look for, which the main criteria I look for with Mainstay is multifidus atrophy, which is something that, especially on reports, the radiologists don't even usually look for it. So it took even a little bit of time with me to get the mindset that I had to start looking for that on the MRI.
So Stephen, let me ask you a question. So, we have patients who come in, they have facet disease, they have discogenic disease, they have modic end plate changes, they have all these things going on, and then they have the atrophy of that muscle, as you mentioned, the multifidus. I think it's wonderful. You and I, when we started working together many years ago, we only had a few tools. Now we have all these options. I guess the thing I really think is important for our listeners to know, coming from someone with your knowledge and your experience, who is the Mainstay candidate? Who's the candidate for Reactivate? Can you give me a profile of what that person looks like?
Yeah, absolutely. And as you know, with all these therapies now, especially when you're looking for the end plate changes, you're looking for facet disease, you want to characterize them a lot by their history. If they're worse in flexion, that's usually a sign that it's end plate changes. The patients I look for Mainstay is not only do you find the multifidus atrophy on the imaging, but you can tell that they're also, the way they present their history is they're deconditioned, meaning they have back pain that's worse when they're standing, when they're walking. They failed usually some of the interventions like epidural steroid injections. They may not have spinal stenosis. We know that with spinal stenosis, you get better in flexion, you're worse in extension. But if you're a patient with axial low back pain that's worse in extension, worse with walking, but you're not finding spinal stenosis, but you see multifidus atrophy, that would be a perfect patient for the therapy.
And let's talk a little bit more of the data behind this therapy. Mainstay just published their 5-year data from the Reactivate randomized controlled trial. What's the significance of that in medicine, and kind of what does that mean for the neuromodulation space in general?
Yeah, that's a great question, because I think, first off, one of the things we've been pushing for in our space is not just level 1 evidence, because we've been starting to do that over the last several years, but it's pushing for longer term level 1 evidence. And most of the trials that we see in neuromodulation, we were happy when they were starting to get 6 months to 1 year, but now even some of the best trials for what we have in neuromodulation are out to 2 years. This is one of the first studies we have in our space that follow patients for up to 5 years. So it's pretty significant in the sense that, one is we're actually demonstrating now with our therapies that we can have long-term success. The other thing is I think how well designed that study was, and not just following the patients out, but you talk about it's a randomized control trial that was double blinded. There's over 200 patients that were in the study, and they're already up to, I think it's 130 patients that are out to 5 years at this point. Some of the things I actually think is more impressive is also they followed not just one primary endpoint, which would be just like a pain score. They actually followed things like ODI and showed significant improvements. They followed opioids, showed significant reduction or elimination of the opioids. So what we're actually seeing is that we can have long-term success with our therapies.
Steve and I was honored to be part of that study, and I think Chris Gilligan and the team there, Jason Hannon, they've done a phenomenal job. And initially, they were close to not making approval at that 6-month mark because the placebo group did really better than expected. And then over time, we saw that separation, and we knew the therapy was really working. And the 5-year data is phenomenal. Two things that impressed me recently, I want your perspective on both and give me your thoughts. One is, I was talking to Jason Hannon recently. I saw the new generator, which, as you know, the volume of that's diminished dramatically. And what does that mean to you? And then secondly, the MRI capabilities have changed recently. Can you talk about both those things?
Yeah, absolutely. I think, obviously there's always first generations of a system. You want to demonstrate that it works. I think you made a great point about that at 6 months that the sham arm was doing almost as well as the therapy. But what we have to realize with this is neurorehabilitation now. It's not a palliative therapy. This is actually, it gets better over time as you're rehabbing the multifidus muscle. And I think that's why over time the patients did better. It just took some time for it to play out. But I think what we're also seeing now that they've actually established a therapy, 5-year data, they have to start improving the product portion of it. What's nice about it is a non-rechargeable system, but previously having quite a large generator. So it's nice to see that having a smaller generator now, the next generation, can be more comfortable for patients. So obviously showing that they're, bringing it back to the patient focused. The other thing that's important is that at first when they launched it, just like you said, they didn't have MRI conditionality. But obviously they pushed for that, and now they have actually a great MRI conditionality where they can run it in a normal operating mode with 1.5T, which is, I can tell you as a surgeon, I mean, especially when you're following pathology in the spine, but this is also true for all interventional pain physicians, it's important that we want to be able to continue to get MRIs and not be withheld from doing that because of our therapies. So this just shows that they've continued to innovate their product.
And this is full body, 1.5 Tesla conditional?
Yes, it's 1.5 Tesla, normal operating mode. There is a max SAR level, but it's quite high. It's actually 2 for the body and about 3 for the head. So
that's Steve, I want to ask you a follow-up question. Patrick, I just want to ask him another follow-up here, if you don't mind. So you have a patient that comes to see you post-laminectomy, and they have severe leg pain. You do a paddle lead. I know that's your preference with the device of your choice. And let's say you get down the road a year or two and their leg's doing wonderfully, but they still have this. When you repeat the MRI, let's say you use you got a burst system going, you have MRI conditionality, you get the MRI, and it shows atrophy of the multifidus. Now, is there any indication to have this device and a spinal cord stimulator in certain patients? What's your thoughts on that?
Yeah, absolutely. I think that's a great question. And I'll tell you more and more that's becoming common in my practice because, as you know, I do a lot of neuromodulation in my practice. I have a lot of spinal cord stimulator patients. And, over time, sometimes you have patients who pain, certain pain factors break through or pain patterns break through. So what I've actually started doing with these patients, the exact one you described, where they're doing well with their leg pain, they may have had a previous lumbar decompression, is the first thing I actually do is evaluate their facets. I want to make sure that stability-wise, it's not because they're unstable, because a decompression was done and eventually their facet hypertrophy and facet disease over time. But if I can rule that out, then I start looking at things like the multifidus muscle. And I have several patients in my practice now that have both therapies.
Stephen, we also see that, these industry-sponsored RCT data looks favorable, due to the strict study criteria, but sometimes you can't really replicate that in real-life world studies. What is kind of reactivates real-world data compared to their RCT? And can you talk about your patients, how they're doing with this therapy in your practice?
Yeah, absolutely. I mean, I think the future for our therapies is going to be real world data. Tim and I have worked on several papers together looking at, collecting even like hundreds of thousands of patients through market scan databases. Because I think over time, it's not just going to be these level 1 evidence, RCTs, which tend to be run by industry. I think we need to have real world data to show that in our hands, in the physician's hands, the patients continue to do well. And actually, Mainstay did that by a recent publication where they combined actually RCTs with some of the real world data and show that they actually mirrored each other. And one of the things that they did is they actually also looked at it by age group, because the original thinking with this was that this was always just going to be middle-aged patients, maybe in their 50s. It wasn't going to be the older population or the younger. It turns out that when they characterized it by all different age groups, all the patients did exactly the same. And they looked at all three things like ODI, VAS, EQ5D, and showed that on all three of those that there was no difference based on age. So it also showed that, like, comparing it to real-world data, it mirrored the randomized control trials.
No, that's phenomenal. And I think that's, Patrick, great question. That's so important. And we've had so many devices that never quite could be reproduced, and that's worrisome. Stephen, I have a question I hear a lot from colleagues of mine, and I want your answer to this. So, if you had a patient come to see one of your local pain people, let's say Dr. Fishman or someone near you, Dr. Fishman will say to them, we're going to do a trial of stimulation. We're going to see your response rate, how you respond. And if you get 80% pain relief or more, or 70, whatever his number may be, 50 or more, we're going to send you to Dr. Falowski for a paddle lead. Mm-hmm. But with this device, there is no trial. So how do you explain? So the question I get a lot from nurse practitioners and physicians and PAs is, how do you explain to a patient, we're going to go straight to a permanent device without a trial? How do you present that to the patient?
Yeah, I think it's an interesting discussion, because we're used to things like, I present to patients, usually this is the only surgery you get to try out first when I talk about stimulators. The perspective, I think, changes for the patients when I tell them that you have to think about this as rehabilitative, meaning I'm going to implant it, but you're not going to get immediate relief. It's going to be over time. And I usually talk to them about, with physical therapy, especially the patients who have done physical therapy, who've had some type of improvement, they understand that it's a slow, gradual improvement. I give them the analogies, like when you're working out, you don't just build muscle overnight, like it takes time. So you have to kind of give them the analogies that this will take time. This is going to be rehabilitative for your muscle, and you're also going to have to work at it. It is sometimes hard to talk about having an implant put in the body with them, but I also tell them, everything's small, it's underneath the skin, you're not going to see it. Some of the limitations before were the MRI, which, because then they do actually have a restriction, but that's no longer the case.
Stephen, you mentioned this rehabilitative. This is a great segue into my next question. There's several peripheral nerve stimulator therapies out there that target the medial branches. Can you talk a little bit about the difference between Reactivate's restorative therapy and these other systems and kind of their mechanism of action?
Yeah, and actually you said it best. It's the idea of the mechanism of action. Most of the peripheral nerve stimulators on the market now that are trying to do the same thing or imitate what Mainstay is doing is they look at it from a palliative approach. It's more of activating sensory fibers. Mainstay is directed to specifically activate pure motor function of the multifidus. It fires for 30 minutes twice a day. The whole mechanism of action and the way you look at it is more rehabilitative or restorative than it is palliative or sensory. The other thing is that no other therapy on the market can demonstrate 5-year data at this point, also demonstrate that it's safe at 5 years. And I can probably tell you the last thing, by having experience implanting these and working with the companies, you also now have a company that is dedicated to only this. Their rep support is trained on how to program these patients and only take care of these type of patients, as opposed to, other peripheral nerve stim companies, which are dealing with multiple different diagnoses, and there isn't a true experience of this is how you program this patient or this patient. So having a dedicated company to one therapy, I think, is probably also what gives them that impressive 5-year data.
Great. So Stephen, July of 25, so time flies. So July 24 will be down in Miami, July the 11th to the 14th at Aspen. July of 25, he'll become president-elect, as Dr. Chakravarthy Vice President Dr. Peterson, our current president, is doing a fantastic job. And she has another year and 2 months to go, thankfully. So she's working on the NFL project, the poster to podium, and so many things with us. So can you talk a little bit about what you've done at Aspen, what your successes have been, and what kind of what your future holds in working with the society?
Yeah, absolutely, Tim. I mean, I think and everyone knows I'm very passionate about this space, and I'm actually very passionate about Aspen and what we've all been able to accomplish there. That's one of the great things about Aspen is that all the physicians like yourself, Tim, Dawood, we all work together to try to make the society work and also bring these therapies to all the physicians out there, young and established. One of the things that I've taken pride in Aspen is I've always tried to build up the collaboration with surgeons. I think there's, years prior, there's also been a lot of animosity between the spine surgeons and interventional pain and who can do these therapies. And the one thing I liked about Aspen was I was able to build off that passion I had of collaboration between all the specialties. And a lot of the way we've done that, too, is through the educational offerings that I've been able to work with in Aspen with the cadaver courses. Started off with the Falowsk course, and now we've actually built that up tremendously, expanded it now to the master's level course where we're actually exposing everyone to all of the new therapies. Aspen's become the only place that now all these therapies, you have accessibility to them there, and you can be educated on them and learn there. So I think I like to think that those things that I'm passionate about, I've been able to bring out in Aspen.
Stephen, because all the work you've done and all the publications you made, you get approached by the medical device companies all the time. It seems like whenever you give a talk, you have 20 to 30 disclosures out there. I'd like for you to elaborate, how do you decide who to partner with and who to speak for?
Yeah, absolutely. I used to always make the joke that when I had all those disclosures up there that I work for so many that I can't be biased to one. But the truth of the matter is that I believe competition builds innovation. I will work with almost any company. What I say is behind closed doors, which means if you need help with product development so I can help build competition and innovation, if you need help with an advisory board, I'll be glad to take part in that. I also even love to just do even educational courses for the companies. But I hope that what a lot of people see is I feel that the way I keep my credibility is to actually get on a podium and speak for one company. I usually only choose one company, which everyone knows at this point is Abbott. I'm very passionate about the burst DR therapy. But I also now, Mainstay, I don't view as competitive to the spinal cord stim space or consulting with these other companies, which is why now I also speak for Mainstay. So I think from my standpoint, I like to only speak or get on a podium for one company, but I'm more than willing to work behind closed doors to build actually that competition, because it's true that you don't want any of these companies to ever become complacent. You want to build innovation off of it. So.
Stephen, it's been a great discussion. We'll give you a final thought, and then Patrick and I will close.
Yeah, let me see. A final thought. I can tell you. So one, that's for the therapy with Mainstay. For the patients that I've used it on my practice, it's actually been quite life-changing for a lot of them. And one of the patient ambassadors that the company uses came from my practice. It was an Afghanistan veteran who actually got blown up by an IED, tried to actually continue on in the special forces, but was unable to do it, had to get medically discharged. And after all these years of dealing with pain, he didn't want to go on opioids. He actually made it to our practice. And one of the first things we realized was he had multifidus atrophy. And we made an interesting decision whether we were going to do an ablation on him. But then after noticing the atrophy on his multifidus, he was also, middle-aged, motivated now. We decided to go with that therapy. And now he has done so well for many years. And he's the patient ambassador for the company, from our practice. So I think that using the therapy has really changed a lot of the patients' lives in my practice. But the other final thought is just I'm very passionate, as you know, about neuromodulation, being involved in this space, educating, collaborating. And I think I hope that everyone who watches these podcasts, that's how they start to feel as well, so they can give back.
So, Steve and I think thank you for treating our military servicemen. I certainly love when we get those patients. My son-in-law is Black Hawk pilot in the Army, and I think to keep that young man that you treated off opioids and off of major surgical, more of that. So great job with that. Great job with your work in Aspen. We really appreciate you, and I think all the work you've done with all the innovation has been really changing the life of many people. So certainly thank you for all that, and thank you for being our guest today. I think it's been a very good discussion. I think we've learned a lot about Reactivate and multifidus stimulation. Patrick, I think Stephen was a great choice and guest. So good job.
Yeah, I think he was excellent. Thank you, Stephen, for coming on. I really appreciate all your time and talking about the therapy and also kind of all your work you've done in Aspen. This is great. Like we talked about at the very beginning, we're trying to build each other up and collaborate. And I think you've done a great job of that. And then also, Mainstay, they've done a phenomenal job at long-term data. We talked about this, Tim, last episode with Intercept and Boston's acquisition, is these companies really putting in their effort and their research and their time to doing it the right way, building up these companies, building these long-term studies, and then converting it to real-world studies. So kudos to Mainstay, and hopefully we get many more companies doing this in our space. So I appreciate you guys coming on again, and this wraps up Season 2, Episode 2 of the Pain Unfiltered podcast. Thank you all for joining us.
Goodbye, everybody. Goodbye. Take care.